بسم الله الرحمن الرحيم. I'm Dr. معن البري from طيب University, Maghribi Eye Center, Medina, Saudi Arabia. I'll be talking about Phakic IOLs in keratoconus. I declare no financial interest in any product or device mentioned in this presentation. Only a subset of keratoconic patients with adequate quality best corrected visual acuity can benefit from this phakic IOL implantation procedure. So proper patient selection is essential for this cornea-sparing procedure. Requirements for this procedure include halting the disease progression, then improving the shape by regularizing the deformity, and finally minimizing the refractive error. It's an off-label procedure that corrects spheres up to -20 diopters and regular cylindrical error up to 6 diopters, but the downside to this procedure is that it does not correct the commonly associated higher order abrasions such as trefoil, comma, and spherical abrasions. Only stage 2 or better on the Amsler-Klume classification can be implanted with these phakic IOLs. The keratoconus needs to be stable for 1 year post-corneal collagen cross-linking, the mesopic pupil being less than 6.5 millimeters with an anterior chamber depth of 3 or more millimeters with a clear cornea and an insignificantly higher order abrasion. The advantages of this procedure is that it corrects high amounts of astigmatism without inducing further new high order abrasions. Plus, the procedure is reversible. Lens power calculations can be performed by an online software where the most comfortable manifest refraction is entered, the anterior chamber depth from a topography machine together with the white to white. Or alternatively, it can be manually measured to achieve the final happy desire of spectacle independence. The surgical procedure is relatively very straightforward, where the lens is inserted into the posterior chamber on an average time of 5 minutes. If the keratoconus is stable with a central cone, then the residual refractive error can be safely corrected with a phakic intraocular lens. And if the patient has a stable keratoconus but with a decentered cone, then the cone should be regularized with an intercorneal ring segment. The residual refractive error can later be corrected by a phakic intraocular lens. And if by any chance the keratoconus turned out to be unstable, Hafidi et al. Has shown that the CXL has no effect on the optical and material characteristics of the phakic intraocular lens. And if the disease was unstable with a central cone, then the disease should be stabilized first by corneal collagen cross-linking. The residual refractive error can later be corrected by a phakic intraocular lens. De Ruger et al. Found that the mean endothelial cell loss in keratoconic eyes was less than 5%, and that was comparable to myopic and hyperopic phakic intraocular lens implantation. And if the disease was unstable with a decentered cone, then the cornea should be regularized by an intercorneal ring segment or a topography-guided PRK with simultaneous or sequential corneal collagen cross-linking. The residual refractive error can later be corrected by a phakic intraocular lens. And if the disease was advanced, Malhero et al. Found in a retrospective case series analysis with long-term follow-up that there was continuing endothelial cell loss of 8%, 13%, and 14% at 1, 3, and 5 years post-op in phakic IOLs after DALC, whereas Alfonso et al. Found a mean endothelial cell loss of 8.1% in phakic IOLs post-PK at 24 months follow-up, though there was a disadvantage of phakic IOLs in DALC over phakic IOLs in PK eyes. Whereas Rocca et al. Interestingly found that ICLs for treating refractive error in pseudophakic eyes post-PK had a trend towards a more physiologic rates of endothelial cell density loss at 18 months follow-up. So in conclusion, phakic intraocular lens implantation is an effective option in improving visual acuity in patients with keratoconus who do not suffer from visually disturbing higher order abrasion. One needs to halt the ectatic process, improve the corneal shape, and then minimize the residual refractive error. Also, one needs to follow an algorithmic guideline. The procedure has the advantage of being reversible. Patients gain sharper visual acuity, they maintain their accommodation, they gain spectacle independence. It's a cornea-sparing procedure and has very predictable results. And thank you for your attention.